Okay. Okay. Thank you for inviting me for this lecture. So the study that I have been invited to discuss is sequential treatment of afatinib and osimertinib or other regimes in patients who have advanced non-small cell lung cancer harboring EGFR mutations. Results from a real-world study in South Korea called as RESET. So we know that lung cancer is a leading cause of cancer-related deaths. Even in Korea, it is the same. Afatinib is superior to gefitinib as a second-generation TKI. 50% of patients have a T790M mutation when they take afatinib. An AURA study has shown that there is a high ORR and PFS with osimertinib in those patients who have already been treated with another TKI. They have a T790M mutation. So real world studies are better in the way that they have the poor prognostics patients like elderly patients who have poor performance status, who have the uncommon EGFR mutations and who have brain mets. Geotag was a retrospective observational global study which showed that the median TKI period of afatinib followed by osimertinib was around 27.6 months, and patients who had a DEL19 they did better. Also, 50 Asian patients were included in the study, and the median time on TKI was actually very good, 46.7 months. So this is a similar kind of study that was done, a real world study in South Korea. So it was a real world experience of sequential treatment of afatinib and osimertinib across 16 medical centers in South Korea. Inclusion criteria was age more than 19 years, EGFR mutated TKI naive advanced stage 3B, stage 4 NSCLC, treated first line with afatinib and second line with either osimertinib or other treatments. The exclusion criteria, patients who were not treated afatinib first line or osimertinib second line and who were initially treated with CTRT. This is the patient consort diagram. So initially 737 patients were enrolled. However, almost a huge chunk of patients, almost half the patients, 413 patients were excluded because of multiple reasons. I think the more patients because of the lack of data actually. And 324 patients were then randomized into two groups. Group A, 126 patients who had a T790M mutation and therefore received osimertinib, and 198 patients in Group B who did not have a T790M mutation. They received other therapies. Now, the outcome here, primary outcome was the time on treatment. Again, subdivided into time on treatment 1 from afatinib to tumor progression and time on treatment 2 from second line therapy to tumor progression or death. And the overall treatment taught was T1, taught 1 plus taught 2. The secondary outcomes were the overall response 1 and the overall response rate 2. That is the patients who had either a complete response or a partial response. And the disease control rate 1 and 2, which is the patients who had a complete response, partial response, or a stable disease. The overall survival as well. Now, if you look at the baseline characteristics, the two groups are well balanced. There were more patients who had a stage 4 disease in the group A as compared to group B, and there were more patients who had a DEL19 mutation in the group A as compared to group B. More patients in the group B had new or aggravated brain mets as compared to group A. Now, if you look at the results, in the primary results, the overall time on treatment was better for the group A. That is the afatinib followed by osimertinib arm. It was 35 months versus 20 months in the group B. The hazard ratio is quite significant. If you look at the time on treatment 1, again, the patients who were in group A did better. I think this is because more exon 19 deletions were there in the group A as compared to group B. And if you look at the time on treatment 2, that is post afatinib progression, it was 11.9 months versus 5.1 months. So definitely the group A did better. It was clinically significant. If you look at the different subgroup analysis of which factors influence the adverse results, it was mainly the poor performance status, advanced tumor stage, tissue type other than adenocarcinoma, presence of liver metastasis, and no adjustment of afatinib. Interestingly, they showed that patients whose dose of afatinib was adjusted had a better response. And if you divide into TOT1 and TOT2, so patients who had an advanced tumor stage and liver mets had a decreased TOT1, and patients who had a presence of liver mets, they had a decreased TOT2 in the group A. If you look at the secondary outcomes, the overall response rate was 75 versus 65%. The overall response to was 40 versus 20%, so definitely significant. If you look at the disease control rates 1 and 2, it is 97 versus 90% and 94%, 75%. If you look at the overall survival, it was not reached in the group A versus 38.5 months in the group A. So definitely as a whole, the group A patients did better than the group B patients. So conclusion, this was a real world study. So poor prognostic factor patients were included. The overall time on treatment was significantly better in the group A as compared to group B, even when all the characteristics like smoking status or EGFR mutations were considered. And it was numerically superior with respect to the overall survival, the disease control rate, as well as the overall response rate. Poor performance status, advanced tumor stage, tissue type other than adenocarcinoma, liver metastasis, and no adjustment of afatinib. These were the adverse factors related to decreased TOT1. And all patients in the group A, they had a T790M mutation, whereas they did not have in group B. So it is possible that the T790M mutation affected the natural history, and it is not the sequential treatment which affected the natural history. So the limitations, it was a retrospective study, so selection bias in this classification is possible. The time of treatment 2 was shorter than time of treatment 1. This is opposite to what was in geotag, but in practical experience, we always see that after progression, the time of treatment is usually lesser. The survival data was not mature in the group at time of analysis. A lot of patients are excluded, so it is not feasible to obtain more detailed information, such as patients who received other treatments or the frequency of T790M. And it is possible that the T790M mutation itself had a impact on the biology and the overall outcome as compared to the non-T790M, because we know that there is no standardized treatment for the non-T790M patients, and generally these patients might have an inferior survival outcome. Thank you.